Welcome, everyone. I am super excited to be here today for another episode of Move Well, Live Well, Perform Well. Today, we are going to be talking all about knees. We're talking about soft tissue injuries around the knee. We're talking about running. We're talking about what running does to your knees. We're talking about skiing. And I know knee specialists love skiers because it keeps them busy after the ski season. And we're going to try and bust a few myths about is running bad for your knees, and how do you minimize skiing injuries and all sorts of fun, interesting things. So I am super excited to be joined today by Mr. Kash Akhtar. Kash is a consultant orthopaedic surgeon. He works at the Cleveland Clinic and he specializes in soft tissue knee injuries, including ligament reconstruction and meniscal pathology, including meniscal transplants. He's worked for lots of years in the NHS and recently retired from that, and now focuses his clinical practice in the private sector. Alongside his clinical work, Kash is a senior academic who teaches and trains medical students, doctors and surgeons in orthopaedic surgery and surgical education. He's also widely known for his educational work on Instagram, where he's built quite a large following as the knee doctor by breaking down complex knee injuries, surgery decisions, and rehab principles into clear, evidence-based advice for athletes and everyday people. And Kash's work bridges elite-level orthopedics and real-world knee problems. He is also the founder of OrthoHub, a podcast, and he runs the Cleveland Clinic podcast as well. So he's a bit of a guru in this space. So I am excited to have him in here today and to discuss.
Thanks for having me, Simon. It's nice to be in a different studio. Lovely setup here.
Yeah, very nice. It's a nice space here in sort of central London. So It's great. So welcome. And we're going to just dive in, Kash. People get so worried about knee injuries. Like, there's quite a dearth of them. Why do you think that is?
So I think it's multifactorial. We know if you've injured your shoulder, your wrist, your elbow, you can kind of accommodate that temporarily and do other things. If you've injured your knee, any of your lower limb, it's going to impact the way you walk, the move, your mobility, your independence. And the challenge is then you look at the hip, the knee, and the ankle, and the hip inherently is a really stable thing. It's a ball and a socket.
Yep.
And there's not much soft tissue around there. There is some, but the ball and socket do all the work. The challenge with the knees is that that they have bones, but the majority of the stability is through tendons, ligaments, capsule, other soft tissue structures, which are at risk of injury. And actually, if you look at the bones are basically, you've got two balls on your femoral condyles on a relatively flat tibial plateau. Mm-hmm. That's inherently not stable.
Yeah. I mean, it's meant to be a hinge joint, but there's lots within that in terms of the micro movements, aren't there?
So everyone calls it a hinge joint, and fundamentally it is, but it's so much more than that. And the thing is, people forget. So in your hip, it's a ball and socket, it goes around. In your knee, you've got 6 degrees of freedom because you've got flexion extension, varus valgus, internal and external rotation.
Yep.
Then you've got anterior and posterior glide between the tibia and the femur. You've got medial and lateral shift.
Yep.
And you've also got compression and tension.
So it's a really simple joint.
Yeah. And the other challenge with the knee is that when you're doing sport and certain activities, between 5 to 8 times your body weight's going through your knee. And so huge load on something that's incredibly mobile and active. And so if you blow out your knee in some way, then the fact is that's your mobility, your independence, your confidence, even your sporting activity, and all the benefits, psychological and else that goes with it.
And they get grumpy.
Yeah.
These knees when they are blown out or painful along the way. Okay, so the knee's a complex joint, okay, in terms of it's not a simple hinge joint that everyone sort of knows, and there's lots of degrees of freedom. What keeps a knee strong and stable? What are the things that you need to help to optimize your knee?
Yeah. So obviously you've got your inherent natural stability through the bones, tendons, ligaments, capsule structures, menisci. And the thing that people can do to strengthen their knees the most, as you know, you'll know better than me actually, is muscular control.
Hopefully, yes.
Muscular control of the knee is the most important thing. And people, that's through strength and conditioning, through appropriate proprioception. And the other thing that people can then train and load. Knees need load. And I think that's a real misconception.
So we're gonna touch on that.
Okay.
That you know, are squats bad for you? You know, I work with lots of different surgeons and specialists, and they're like, oh, don't do squats.
Yeah.
You're going to harm your knee.
Yeah.
Don't load it.
I think my biggest challenge in medicine has probably been fighting that misconception.
Yeah.
Because a lot of knee surgeons say it, and I understand why they say it. But if you look at, as an academic, I look at a lot of literature, and if you look at all the biomechanical and clinical studies, squatting is not bad for your knees. The fact is that appropriate squatting with appropriate technique is really good for your knees.
Yeah.
And as you know, it's one of the key exercises that people get after an injury to try and rebuild strength.
It's one of our most common functional movement patterns.
Yeah.
You know, we sit to stand 50 times a day.
Yeah.
If you can't squat, you're up shit creek, excuse my French, because you need to be able to go through that movement.
Yeah, no, I speak French, so it's good.
Yeah.
But the thing I would say is that, and squatting in a healthy knee is absolutely fine. The time where squatting can become a problem is if there is some pathology in your knee, particularly in your patellofemoral joint.
Yep.
And then when you're squatting, you're getting up to 8 to 10 times your body weight going through your patellofemoral joint.
Yep.
And if you're missing cartilage, you are causing some discomfort there. The actual evidence would suggest that you're not actually accelerating osteoarthritis particularly, but you're causing pain and swelling that then switches off your muscles and has a negative effect. And the challenge is then if people are squatting with poor technique or they've got underlying damage. But if you haven't got underlying damage in your knee and you've got good control and you've got good technique, it's a great exercise.
Yeah.
I've never told anyone not to squat ever.
Great. That's nice to clear because, you know, it's a simple, easy way. And yes, okay, there's the devil is in the detail some of the time in terms of how you load someone and the stages at which you can put load in the knee. Because if you a bit too aggressive with squat patterns early on and someone's got a grumpy patellofemoral joint, it can wind it up.
Yeah.
So you need to start with isometrics or different types of exercise.
Or shallower squats and build up.
Exactly.
And I think the thing is that when people are doing it, particularly if they're doing repetitive squatting and they're doing it when they're fatigued and there's not enough rest in between sets, that's where you can sustain an injury.
Yes.
Or really exacerbate something.
And that's where with doing rehab with some of these particular patients that we see and we share, we often like to use different tools like blood flow restriction training because that is a really easy way to get load into a joint, but it will get load into the muscle. But you're not having to heavy load and you're not having to do heaps of repetitions. So you're protecting the joint.
And blood flow restriction therapy is something that I've only really come across in the last year.
Yeah,
I've looked into the research and I was really impressed with the research because particularly since I've been doing meniscus transplants and cartilage transplants, a colleague of mine, Tim Spalding, and I at Cleveland Clinic London, we've set up the Centre for Knee Preservation and we're very fortunate we get to operate together on a Tuesday morning. These big cases. And in those cases, we want to drive load through the knee appropriately, but we want strength and conditioning. And so we've got to strengthen people at lower load. And so then we're looking at adjuncts such as neuromuscular, stimulation, but in particular, blood flow restriction can really drive hypertrophy without causing injury to meniscus or cartilage.
So I had Hytro, the founder of Hytro, Warren Bradley on my podcast talking about it. I don't know if you've come across Hytro, but that's...
I've used Hytro actually. I've met a few of the team. Dan Howes came.
Okay, yeah.
In fact, Dan took me to a gym.
And Dan, just for everyone listening, Dan is a S&C sort of guru, a performance expert, and he works with Hytro and he's a bit of a guru around blood flow restriction.
And he spent a lot of time working with American sports teams on blood flow. And so Dan got me a pair of fetching shorts.
They are lovely, aren't they?
They are,
yeah.
And cranked them right up. And then got me just doing quite simple goblet squats.
Yeah.
And I did 4 sets of goblet squats and we did a few different exercises. And then I couldn't walk downstairs for 2 days. And I was using an 8 kilo weight. And you think that's nothing.
Yeah.
And so it really drove home to me just what impact actually relatively low exercise, low load can do.
Completely. Yeah. And we've used it for a lot of years. In the clinic, blood flow restriction, and Hytro in particular because it's easy. It's just low faff compared to...
I love the fact it's just not connected to hydraulics. There's no pneumatic tube.
It's all manual. It's super easy. And the changes that we get, we can now rehab an ACL and at 3 months have very little muscle atrophy difference between the two sides. Whereas previously, if we use Hytro, if we use blood flow restriction, whereas previously we'd be playing catch up on that muscle bulk, that hypertrophy for a long time.
Sometimes 9 to 12 months, right?
Yeah. And if you can, if you can hypertrophy your muscle, you're going to be building strength at the same time.
Yeah.
So it's a really nice adjunct.
And it's interesting for me because a loss of strength is a loss of so muscle atrophy, particularly the quads, is 100% of the time after any knee operation.
Yep.
And then
Even just after injury, though, I mean, the VMO will switch off within 48 hours.
yeah,
The studies, you inject saline into the knee, the VMO is switched off almost immediately.
I've seen someone in clinic, half an hour ago, who had a meniscus injury about 2 weeks ago,
Yep.
and has got noticeable reduction in muscle bulk and definition in that thigh compared to the other thigh.
Yeah.
Someone who's quite active.
Yeah.
A PT.
Yeah. And it's very easy for that to switch off. But yeah, hydro or blood flow restriction can be really, really useful adjunct. Now, we've digressed a little bit.
Sorry, it's kind of what I do.
So coming back, so the big take home from that was that squats are not bad. Done appropriately, they're fantastic exercise for knees to build strength, because what we need to do to have a healthy knee is to have a strong, stable, well-balanced knee.
Yeah.
And the balance between quads and hamstrings and posterior chain is really important as well. And a lot of the time the guys will train the quads but forget the hamstrings. And typically when we come to an ACL, the hamstrings become very, very important as well, don't they?
They do. And as you mentioned, load is good for the knees. Load is good for muscles, but actually cartilage needs load.
Yep.
And cartilage will actually thin and atrophy without load.
Yeah.
And so cartilage needs some load on it. And the thing about squats is there are so many variations of squats.
Yeah.
Even a box squat, if you want to limit someone to what they're doing, from bodyweight squats to squats with blood flow restriction on to with weights. And there's so many sumo squats, so many variations.
Correct.
All those squats I can't do, like goblet squats and pistol squats.
Yeah.
There's so many variations that you can really challenge people. So as long as you don't have any major patellofemoral cartilage problem,
Yep.
and they're done with good control, you are completely fine to do squats.
So, Kash, what about this? What about deep loaded squats? In my world, because most people that we're seeing have pathology, if we're talking about knee pathology, I'm generally getting people to, 90-ish degrees.
Yeah.
And I don't see huge benefit from squatting much deeper than that, particularly at heavy load.
I know I do.
What are your thoughts on?
So the deeper you go, the more increase there is in shear and pressure on cartilage.
Yep.
And then in really deep flexion, what starts to happen is that you start to get meniscus extrusion.
Yeah.
Particularly the lateral meniscus starts to come out the back. And that's what it's designed to do.
Yeah.
But you really are forcing it. And that's where then there is a risk of injury.
Yep.
If it's done when tired, when not appropriately rested between sets, or if it's poor technique or too much load.
Yep. Okay, cool. Glad we've sort of covered that. We're going.
I really hope that we can almost. I don't think we will quash this. I think it will still keep going for decades.
Because consultant surgeons who will remain nameless will often go avoid squats, avoid lunges, don't. And yes, for periods of time you've got to modulate load. You know, but.
And I was going to say, I think part of it is because people come in and go, "When does your knee hurt? It hurts when I squat."
Yeah.
Don't squat.
Yeah.
And the thing is, it's the squatting that's going to make the pain go away.
Yeah.
For many of them.
And driving but it's more nuanced than that. In that, okay, it's got to be appropriate technique, appropriate load, with the right sort of form, and done in sequence so that you're building the support around that area. Okay, we're going to try and move on because we're not going to cover any of our questions if we don't. So, tell me about some of the most common soft tissue knee injuries that you see around the knee.
Yeah. So the most common injuries, so essentially when it comes to soft tissues around the knee, you're looking at meniscus, ligaments and tendons.
Yep.
Meniscus problems are the most common thing that I see.
Okay.
Medial meniscal tears are by far the most common.
Yep.
Lateral meniscus as well.
And medial meniscal tear is probably the better one to have as opposed to the lateral meniscus. Would you?
Yes, I would. So the lateral meniscus is really structurally vital.
Yeah.
If I just go back to the bone, the shape of the bones, on the inner side of your knee,
Yep.
it is like a mini ball and socket, the medial
Yeah.
compartment, and it's quite stable. And if you were to take a meniscus out, a buckhandle meniscus out in a professional footballer, you'd expect them to probably still play for another 10 years.
Yep.
The lateral side, the femur and the lateral tibial plateau are designed as two balls balancing on each other. And the meniscus, almost like an egg cup, is the thing that gives it stability.
Yeah.
You lose your lateral meniscus, they start shifting around,
Yeah.
shearing off cartilage. And that's the number one cause of professional footballers retiring early.
Yep. So chondral wear on the articular surfaces there.
Resulting in accelerated osteoarthritis.
Yep.
So if you had to choose one, you'd probably take the medial meniscus.
Yep.
As a surgeon, we're quite like operating on the lateral meniscus. There's more space for us to get in there.
Yeah. Okay. So you see lots of meniscal stuff. You see ligamentous stuff.
Yeah. And then we look at ligaments.
tendon.
So, yeah, I'll come back to the tendon. So the ligaments are the thing that I see most commonly after that. The most common is probably an MCL sprain or an MCL injury is more common. And then it's ACL tears
Okay.
and ACL injuries. Lateral collateral ligaments and posterior cruciate ligament, the PCL, are relatively rare in comparison.
Okay. And so meniscus injuries, if we touch on those, they generally wear over a period of time anyway, naturally, don't they? And we often see different types of tears within the meniscus. And the meniscus are these sort of C-shaped sort of fibrocartilage sort of structure that acts as a shock absorber to the knee, doesn't it? And there's a difference between a degenerative tear and an acute tear.
Yeah.
Can you explain what happens there? Like an acute tear is post a particular injury.
Yeah, and most people, and they can nearly always pinpoint an event. I was running, I put my foot down, I turned, and I felt a snap, a tear, something go, and that's a meniscus tear. The thing about meniscus tears is that they're common. So in your 30s, 4% of people in their 30s will have a meniscus tear.
How many?
4%.
Yep.
When you get into your 40s, it is between 15 to 20%.
Yep.
So you stop a 40-year-old in the street, take an MRI, 15 to 20% have a meniscus tear they don't know about. Once you get into your 50s, it's between 30 to 50%.
Yep.
Up to half. And once you're above 50, above 50s, once you're in your 60s and above, near around 50, more than half the people will have a meniscus tear on MRI. Majority of the time, they don't know anything about it. It's almost like a sign of aging. It's like grey hairs or wrinkling. Yep. You know, that meniscus tears happen.
If you had hair, that is.
If I had hair.
And me, that is.
But, and so it's a sign of aging in that sense. And so so meniscus tears are common. Lots of people have them. And if you start MRIing people in their 60s and 70s who've got pain, and even in their 50s, almost a fair proportion will have a tear.
I mean, it's like most pathologies, disc pathologies, shoulder cuff pathologies, labral tears in the hips.
Yeah.
You pull 100 people off the street.
Yeah.
In 50 to 60% of them, at a minimum, you're going to find pathology.
Totally. And so the traumatic tears are when you've got healthy tissue that's been torn.
Yeah.
The degenerate tears are when you've got essentially weakened or aging tissue or tissue that's not as good quality as it was, that then is more prone to tear. That can often tear and people don't even have symptoms.
Yeah.
But then they can go on to cause symptoms, some of them. The thing, there's a slight misnomer. A lot of MRIs I see in people in their 20s and 30s reported a degenerate type meniscus tear.
Yep.
And radiologists use that phrase, and that's not accurate.
Yeah.
But we don't treat people because they have a meniscus tear. We treat them if they are symptomatic.
If they have symptoms.
And if they've not responded to other treatment modalities.
Yep. So in terms of differentiating between, let's call it the degenerative tear, for example, versus an acute tear. The degenerative tear, would you ever intervene? Because in the past, 15 years ago, we were probably operating on lots of those and trimming them back. But we now know that actually probably the worst thing we can do generally, unless they're particularly symptomatic.
I would totally agree. And it's interesting. So I was a junior doctor 20 years ago now.
Are you that old? Really?
Yeah, an old man.
Really?
Yeah.
I mean, you don't look it.
You're too kind. Hopefully people are listening and not watching. But 20 years ago, I used to work for a consultant who would put people down
Who would remain nameless,
list them for an arthroscopy, and at the same time list them for a knee replacement 6 months later. So he had a diary, and he'd put, okay, you're having your arthroscopy the 1st of January.
But he's not incentivized because he's working on the NHS.
Yeah, and then you're having your knee replacement on the 1st of June. And
I mean, what does that say?
I think you are right that historically we did do too many arthroscopies in degenerate meniscus tears as a profession.
Yeah.
And I think that was, I think some people are slightly can be unkind. And I think there was an element of trying to help people.
Yeah.
And that was the practice at the time, thinking,
Yeah.
I'll do something. If there's a problem.
Because people want, sometimes you're possibly the last man standing or the last resort.
Yeah.
And you're like, oh shit, I've got to try and do something.
Yeah. You want to help the person in front of you.
Yeah.
And people in the NHS in particular, when they've waited, let's say they've waited a year to get an MRI, result, 6 months of physio, another 6 months to a year to see a consultant. They sometimes waited 18 to 24 months before they see you. And when they get to you, they don't want to talk about normative management.
No.
I want a cure now. I've waited 2 years. I've not been able to work as a builder or do what I want to do with my children, operate. And it's a difficult conversation. And it was a conversation I would have, and I'd make my own life difficult by pushing back.
Yeah.
Sometimes it's easier just to go with the flow.
Yeah.
And so I think we did do too many and there were, look, I won't lie to you, there were other ulterior motives that people operated too much in the past.
Yep.
And now we have a better understanding of who gets better. So the degenerate tear, me doing an arthroscopy in someone in their 60s or 70s is very rare.
Yep.
But if someone came in with true mechanical locking or jamming, as I've seen today, that person, I would offer an arthroscopy.
So that where there's clicking, where there's
not just clicking.
way sometimes.
So sometimes they can't get the knee fully straight or fully bent because something's caught in the way.
Yep.
A feeling that something catches and they've got to kind of, and then it releases with a click or a bit of pressure.
Yep.
And quite symptomatic of that, that's the time I would consider an arthroscopy. But the chances are that person will have a degree of arthritis. So I have to consent them. And I say, look, I'll get rid of your mechanical symptoms. There is a chance that your arthritis pain may get worse.
Yes.
But
because you can run the risk of opening a can of worms a little bit with that process,
potentially.
can't you?
And so it's a thing that I probably only do a couple of times a year.
Yep.
And I see lots and lots of these cases. And then you've got to be really clear. If pain is the number one indication, I don't operate.
Yep.
If someone's got pain with a meniscus tear,
would you
would
inject?
Yeah.
Like a steroid injection?
So always
or a lubricant?
rehabilitation, strength and conditioning, load management, activity modification, all that.
Yeah. So
painkillers.
Try physio. Make sure that you've had good physio, because there's a difference between physio and good physio.
Yeah.
Like anything. And then some injectables might be on the table.
Yeah. And that's where I would consider something like a hyaluronic acid or more likely a steroid injection if pain is the main driver. Because I can't guarantee, and I don't think an arthroscopy is necessarily going to get rid of your pain unless you've got something like one of those flip fragments that's kind of tucked under the MCL that's really jolly sore.
Okay.
And you can see that on the MRI.
How often can those type of pathologies be missed on an MRI?
Quite commonly. They're not missed, they're not reported. They're reported as a meniscus tear.
Yeah.
But they don't necessarily say there's a flipped fragment beneath the MCL.
Is that because the radiologist is not spending enough time on it, or they're not skilled at?
No, it's not that. It's because they've picked up the tear always. Yeah. It's because I think they don't see the surgical sequelae of it.
Yeah.
I don't think they appreciate the full impact of it.
Okay.
And if someone's got a meniscus that's torn and it's tucked inside the medial meniscus under the MCL, then what happens is often on the MRI, you'll get a little bit of bone marrow edema on the tibial plateau.
Yep.
And it's white hot and it's incredibly sore. It's the most painful meniscus tear. Yep. And you flick it out with a probe, you trim it away, you're only removing 10% of the meniscus. And honestly, it's like you've pressed a light switch. The pain's gone the minute they wake up.
Yeah.
It's amazing. I love that. And so the key is that I look at all the MRI images myself.
Yep. Yep.
We have the report and I go through it with the patient, but I interpret the images myself. If you see a flipped fragment, I mean, that is an absolute slam dunk. I love those.
Yep. Okay. So that's a clear winner in terms of going in, debriding that, trimming it back.
In a degenerate type tear.
Yes. Okay. And so degenerate tears, you're generally trying to not intervene if pain is the main feature.
Yeah.
If there's mechanical symptoms like they're locking, catching, or sometimes sort of giving way, you might intervene.
Yeah. And you don't want to intervene if they've got any arthritis.
Yes.
And without mechanical. But one thing that has changed, it's quite interesting. There was a study called the Metro study that was published quite recently.
Okay.
Randomized controlled trial, 2-year study. And they basically looked, and it was run out of Warwick, Andy Metcalf's group. And what they found actually is that mechanical symptoms are not necessarily the reason. The reason, so 99% of orthopedic surgeons use mechanical symptoms, as you know,
Yep.
as a reason to operate. And they said if someone's got pain that's gone on beyond 6 months without arthritis,
Yep.
those people should also have an arthroscopy, and there's evidence they do really well with it.
Okay, interesting.
So that's a slight change. So if anything, we're slightly extending our indications now based on the evidence, on the latest evidence.
Yep. Okay.
So pain, if there's no arthritis, is beyond 6 months. That's not
And
responding
they've
to
tried
non-op rehabilitation.
Yes, and injectables.
Yeah.
Yep.
Then that would be appropriate to do an arthroscopy for those.
Yep. Okay. And then comparing, say, degenerative tear in the medial meniscus, your lateral meniscus is probably maybe good for surgeons who enjoy operating on them, but less good for that individual because of the consequences down the line if you do need to have something done to it, because it generally accelerates osteoarthritis.
If you have a meniscus tear, your risk of arthritis goes up significantly.
Yep.
If you have it trimmed, it's obviously higher.
Yep.
The thing is that if you tear a meniscus and I repair it and I put it back as God intended, within a week of the injury, your risk of arthritis is still higher than if you'd never torn it. But in the lateral meniscus, we will do everything we can to try and salvage it and repair it in a young person. And I really will push the indications to do repair. And since I've started doing meniscus transplants, I've really kind of picked up so many more techniques and tips and tricks to try and salvage the lateral meniscus.
Okay.
And so I'll repair ones that I would not have repaired 5-10 years ago.
When we come to a repair of a meniscus, you are looking at trying to preserve that meniscus and therefore the sort of bony cartilage, if you like, underlying that, to prevent osteoarthritis and to maintain normal function within the knee.
And stability.
And are they just always acute tears or traumatic tears that you're repairing?
So historically, the thought was that we would want to repair a meniscus tear, ideally, particularly a bucket handle.
Yep.
But any meniscus tear within 2 to 3 months for optimum healing.
Yeah.
But now I push that indication. If I see a tear, I did an Instagram video a few months ago about someone who's had a bucket handle for 11 years, and I repaired it, and he's healed and done really well.
Oh wow!
And so,
now
you can push the indications if it's a repairable tear that's suitable.
Okay, so just touching on this, there's surgeons often suggest that there's white and red components to a meniscus. Red are the ones that have blood supply, and white are the avascular areas.
And in the middle, you've got the red-white zone in between the two.
So meniscus generally, the consensus I thought was when I went through and was sort of studying that, the inner 2/3 has poorer blood supply and the outer 1/3 is the only sort of bit that gets blood supply. Is that right?
Yeah. So the outer has great blood supply, the outer third, as you say.
Yep.
The middle third, the red-white zone, has some blood supply variable.
Yep.
And we would repair those definitely.
Yep.
And the white zone, the inner bit, has no meniscus, no blood supply.
Okay.
You wouldn't repair those.
Okay.
But I saw, but what's interesting is our understanding of a meniscus pathology has really changed over the last few years.
Okay.
So there's a white tear called an LMORT, lateral meniscus oblique radial tear. We now fix those.
Okay.
And I saw a 24-year-old the other 6 months ago who'd shredded his meniscus, but if I'd removed it, he would have had maybe 5% of his meniscus left. He's 24.
Wow.
So I used all the stitches in the hospital, putting it back together, and he's doing very well at this moment. I've told him that it's about as precarious as it gets, but in a 24-year-old, I will take every chance to salvage it.
So when you're repairing someone like that, that's an extreme example. How many stitches, and you're putting stitches into these meniscus?
So they're actually devices. They are stitches, but it's not like a sew on a needle.
Yep.
It's a device on a long, thin thing to go in arthroscopically through the keyhole incision, a centimeter incision, and then you deploy suture and possibly anchors through it to fix it back. An average meniscus tear probably needs 2, maybe 3.
Yep. Okay. And the ones that do well, you're suggesting that actually it doesn't have to be time limited necessarily, as that's what I'd always thought, that actually the more acute ones that you get to earlier, they probably do better.
That's still true. And for a bucket handle tear in particular,
Yep.
the challenge is that if it's flipped out of joint,
Yeah.
out of position, and people are walking on it for months
You're
and
going
months,
to risk tearing that.
you can
further.
tear it, or it can deform and undergo what we call plastic deformation.
Yep.
So it doesn't bounce back. So when you've got a jacket and it's wide, and you bring it back together and you want to zip it up,
Yeah.
it's there. But if it won't physically go back, you can't stitch it, you can't put it back. And so that's the bucket handle meniscus
Okay.
if it's displaced. But the other ones, and don't get me wrong, time is still important.
Yep.
And I know we try and complicate things, but now we've developed new meniscus tears that didn't exist before, such as a root tear. And
Are people just making up names of things just
yeah.
for the fun of it?
no, it's because we've really
And this
increased
wasn't David
understanding.
Root who
No.
made up this one? No?
No, so the meniscus root is where the meniscus is attached into the bone right at the back.
Okay.
And if you have a root tear,
Yep.
it's like pulling a tree out of the ground by its roots.
Yeah. Yep.
And
yep,
so
yep.
biomechanically, if you have a root tear, but no actual tear within the meniscus body, you ripped it out, biomechanically, it's the same as if you have no meniscus whatsoever.
Yeah. 'Cause
Accelerated
it's
osteoarthritis.
it's completely unstable.
It's completely, it's pissing in the wind.
Yeah.
And so then you're looking at, the evidence would suggest if you, a lateral meniscus root tear, a very high chance of advanced osteoarthritis needing a knee replacement within 2 to 5 years.
Okay.
I think it's partly because we did not do MRI scans of people in their 50s and 60s before.
Mm-hmm.
But these are devastating injuries where and they're really low injury, and these are technically degenerate tears.
Yep. Okay.
This is where someone will just get up off a sofa, step off a curb, and bang, the worst pain of their life. They cannot wait to bear. It's almost like they've broken their leg.
Yeah. Yeah.
And that's the root tear. And those I really want to fix within the first few weeks.
Okay. Okay. So speed does matter. But you're suggesting that actually you're still getting some good results, even sort of from
Further out.
historic tears.
Because our techniques, the devices have got better that we repair them with, our understanding and techniques for as a profession have got much better.
Yep.
And we're doing more repairs, so we're getting more proficient at them.
Yeah. Okay, cool. That's interesting. Now, in terms of rehab post, a debridement is pretty simple rehab.
Yeah.
You're just trying to settle the knee. There's no precautions. You can load it. There's lots of variation in terms of after you've repaired a meniscus because you want to protect those stitches essentially. So your 24-year-old who's had, I don't know how many
I
stitches.
put in 10.
Okay.
Yeah. Most I've ever done by far.
You're probably going to have him partial weight bearing or non-weight bearing for quite a period of time.
I had him 6 weeks partial weight bearing.
Yep.
0 to 90 degrees. And for him,
Yep.
I used a knee brace.
Yep.
So things have changed slightly. I in my practice has evolved as I've got more experience. And I pretty much do not use knee braces now after
Yep.
meniscus repair because they slide down. They're a pain in the butt.
Yeah.
They
They're not
actually,
great.
I think they can accelerate atrophy. And there's so many disadvantages to braces. But if I'm doing a bucket handle meniscus repair, a root repair,
Yep.
or something called a full fitness radial tear, or this young guy, then I will definitely use a brace. But I probably use a brace for about 5 to 10% of my meniscus repairs now. It was 100%.
Okay.
And,
Okay.
and the variation for surgeons is there is variation in that because some surgeons do not limit weight bearing
Yeah.
or
Yeah.
range of motion.
Yeah.
And
Do you not routinely?
I do.
Yep.
I keep people. So I say, look, don't go into a deep bend.
Yeah.
I mean, if it's 90 degrees, 100
I mean,
degrees,
any
you know.
decent physio should make that should make sense. You squat, you're increasing the load.
particularly on the back of the meniscus.
Yeah.
And the thing you got to bear in mind though is that the re-tear rate after meniscus repair in the literature globally is about 20 to 30%.
Okay. And when is that highest risk within the first 6 weeks or 3 months?
The first 3 months.
Yeah.
Yeah.
Okay. And so protecting them allows healing, but you need a bit of load as well.
You do. And so that's why I will let them partial weight bear.
Yep.
And because you want some load, and particularly for something like a bucket handle repair where you put it back, because it's all the way around, loading it actually puts load circumferentially around the meniscus and actually drives healing.
Exactly. So putting some good load, as we'll talk about with running hopefully in a second, actually stimulates a healing response.
Yeah.
And that's where I think if you're seeing a physio, you need a physio who's a little bit creative because you can use Compex, you can use blood flow restriction. You can use all these tools, maybe a game ready to settle the knee, but so that you're minimizing atrophy. Because if you can keep load in the muscle tissue, you're going to hit the ground running a lot more when you can load the joint a little bit.
Otherwise, it's just such a prolonged recovery. And as you mentioned earlier, muscle mass correlates with strength. If you haven't got strength, you are going to get pain, swelling, reduced load management, load tolerance of the knee, and you're going to get fat pad inflammation.
Yep.
And that's the biggest bugger after this operation.
Okay, so you see that fat pad, sort of Hoffer's fat pad irritation, can be one of the factors that really flares the knee or perpetuates the recovery process.
I find it incredibly common, actually, and I think people necessarily don't look for it. It is a pain at the front of the knee, anterior infrapatellar knee pain, made worse when people force their knee into extension, flat on the bed.
Yep.
And it can limit extension.
Yep.
And it comes on when people are walking downstairs, and it can cause a feeling of catching or clicking in the early postoperative stage. And that's why I'm very aggressive about patella mobilization exercises and knee mobilization as early as possible.
Yep. So making sure the patella is mobile, not getting stiff. Yeah. So we've dived pretty deep into sort of meniscus pathology, but
I've got much more.
I'm sure we do.
I'm skimming the surface here.
Yeah, but why do some knee injuries, if we're talking about meniscus, why do some degenerative tears settle and then others just don't? I mean, I have a bit of a theory that it's related to how strong and stable the knee is anyway before that. And someone who's always been strong, stable, and they've got a degenerative knee, I know that they're probably going to do all right, and we can quieten it down and settle them if it's woken up for whatever reason. Yeah. But the ones who haven't kept themselves strong tend to be the ones that go on to have a grumpier knee.
That's definitely my experience. If I see someone who's a guy in their 50s, who's a runner, who's running 5K twice a week, doing gym sessions, doing high rocks, people who are active, they generally may do quite well. They will come with clear mechanical symptoms and not so much pain. And you're right, they can manage it. And I've had many of them. And the people who haven't got much capacity to tolerate any reduction in strength or load, they're the ones who, they've got no reserve.
Yes.
And they're the ones who struggle. And the challenge is they're the ones who then are more likely to end up struggling, having injections, going towards a surgical pathway, just because they're not getting better, not because we're looking for work to do, because they're not getting better and they want to get better. And ideally, if you can increase their physiological reserve in the first instance, that's still preferable.
It's strength work.
Yeah.
Is the key pretty much for all injuries,
all knee
not
injuries.
just knees, but hip, foot, ankle, spine, shoulder.
Yeah.
Everything needs to be strong.
Yeah.
Okay, so let's move on to ligament type injuries. You said perhaps the most common ligament injury that you see was an MCL.
Yes.
Now that's generally an acute injury.
Yeah.
But you can have some low grade MCL irritation, people just walking around in terms of how they mobilize and move, can't you as well?
So probably the most common finding on an MRI scan is a phrase that says proximal MCL thickening, MCL sprain, or evidence of previous MCL injury. I think anyone who's ever kicked a ball or done a twisting sport will have that on their MRI. I reckon I see it in 3/4 plus of MRI reports that I see, where it's not where the issue is nothing to do with the MCL.
Yeah. Okay.
And so they are remarkably common.
Yep.
But they are, and so there can be a chronic use thing, but that's quite rare. It's nearly always an acute injury, a twisting injury, playing paddle, football, skiing, felt a twist, immediate pain on the inner side of the knee, and often it radiates up and down. It's not just point; it's kind of up and down.
Okay, so ligament injury. So MCL is most common. Okay, usually conservative management most of the time for MCLs.
Yeah.
How often are you reconstructing an MCL?
Maybe half a dozen times a year.
Okay. And how many ACLs might you reconstruct?
150, 200 ACLs a year.
Yeah. Okay.
Yeah.
So generally MCLs do very well with structured management.
Yeah.
Do you brace them typically?
So I think when we talk about MCL injuries, we grade MCL injuries. And we use, depending on how much valgus opening there is in 30 degrees of flexion, where they open up when the knee's straight. And we grade
And
them
so
1, 2,
just
and
for
3.
people who are listening, valgus is a medial stress where you're opening up the inside of the knee.
Yeah, you're taking the foot to the lateral side,
Yep.
and you're opening the knee up on the medial side to stretch, as if you've got a rubber band on the inner side of the knee, and you're just trying to stretch that rubber band to test it, and you want to see how stable it is and
Yep.
how much it opens up.
Yep.
A grade 1, a little wobble, I would not brace. And
At all. Interesting, because I would brace for a short period of time.
yeah.
Yeah.
So I would not brace in a grade 1 MCL. I would find that I think the bracing would be detrimental to their quads and their recovery.
Yeah.
And those are so inherently stable, they will be fine.
Yeah.
A grade 2 MCL is one I would brace
Yep.
to ideally try and downgrade it to a grade 1 or a grade 0.
Yep.
And a grade 3 is where, and so a grade 1 is a little sprain. A grade 2 is where you've probably torn about half of the MCL.
Yep.
Grade 3 is you've torn almost all
And
of
you
it.
can feel that there's quite a lot of laxity on those
Yeah.
grade 2s and 3s.
There is. And
Yep.
the grade 3 is really lax. And the thing about the thing that differentiates the grade 2 from the grade 3 is that when the knee is fully straight, it still opens up in a grade
Yep.
3. And I would still, and so the grade 3 is the most severe type. And as long as it's, assuming it's not a professional athlete and it's not a multi-ligament injury, where they've torn all the ligaments, I would brace that early and try and downgrade it. And they've got, the MCL has an excellent blood supply and
Yep.
a really good healing capacity.
Yep.
The one thing about the MCL is that if you're going to brace it, you've got to brace it early.
Yeah.
So your point of bracing the grade 1s is not unreasonable.
Yeah.
Because I'm talking about, I've seen someone examine them and have an MRI in front of me. But if you don't, to brace it early, you won't lose much.
Yeah. And for those grade 1s, I put a mild little brace on them.
Yeah.
So not a big,
Like a little, yeah.
not
Not
a
a
big
post-op
Donjoy
brace.
or anything like that
Yeah.
on them.
And even for the grade 2s, I tend to use the smaller ones myself.
Yeah.
The big post-op bad boys are for the grade 3s. But the only challenge with the MCL is that on the off chance it's something really significant, it needs to be diagnosed early.
Yeah.
So if someone's got a serious MCL injury, I don't want them coming and see me at 2, 3, 4 months post-injury because I've missed the window to brace them.
Yeah.
I'd want to see them within a week or 2 of the injury just to confirm where they're at and then brace them. I'm not to operate them, just to get them started on the right track.
Yeah. Okay, cool. But generally, with good management, they generally do pretty well from a conservative point of view.
They do. And let's say if you don't brace it early, they can heal a little bit baggy.
Yep.
The MCL's still a bit slack.
Yep.
But if, say you've got a grade 2 MCL, I would say that 99% of people will never be aware they've got it.
They can get a bit painful and still remain a little bit painful down the line. So, our sports medicine colleagues often might inject the sort of origin, or even sometimes a colleague of ours, Mark Gillett, has put some sclerosing agent injections to tighten them up a little bit.
Yeah. So people would put dextrose in there and various things.
Yep.
I'm not sold on the evidence of that, but I don't think it does any harm. We use anti-inflammatories to get rid of pain.
Yep.
The one MCL injury that you'd say, if it's someone elite athlete, you probably would operate straight away.
Yep.
Because you can't risk them being braced, them breaking down 3 months later.
Yeah.
And if someone's had a tibial avulsion and they've ripped it off the bone at the bottom, that's got a very low chance of healing. But if it was a non-athlete, I would still brace them. And I've had a couple of those heal.
Yep.
But they're the ones that more likely to go towards surgery. And there's a really extreme one called a stena lesion where it's ripped off and flipped into the joint.
Yep.
And you have to go and fish it out and tack it back. And that needs surgery.
Okay.
But that's really rare. I think I've seen one in the last 5 years.
Okay, interesting. So ACL injuries, okay? These are the sort of injuries, the pivoting injuries, where generally you're seeing someone on a football pitch, they've gone one way, they move back the other way, and their knee is driven in, and then they've collapsed on the floor.
Non-contact.
Non-contact,
Yeah.
And often low-speed skiing injuries a lot of the time, unless they're high speed and you've done multi-ligament.
Yeah. So what's interesting, so football, very much non-contact injury. I just turned, the ball went over my head, I turned quickly, knee gave way.
Yep.
Vast majority of the time, no opponent near them.
Yes.
It's not a traumatic injury. And we see that even, elite professional football and Premier League football, we see those injuries a lot.
Yeah.
The skiing ones are essentially you've caught an edge or you've landed awkwardly. I've seen a spate of them over the last year or two of people just getting off a chairlift and their skis getting caught in someone else's.
Yeah.
And the challenge with the ski is that because you've got such long skis and you're fixed in there, the torque is the lever arm is so great that it's wrenching your knee and it's ripping the ligaments and particularly the ACL
And the,
and the MCL.
I think the problem here with that is that, and I'm not sure, as an Aussie, we skied in Australia. There are mountains, but we skied over there. And we'd always keep super strong in the build up to the season. But there's so many people who go skiing, don't do much all year and think they've got the resilience to bloody go and ski. Where you look at, the downhill skis, their quads are massive.
Yeah.
And to resist that torque, to try to protect yourself, you need to be super strong.
You do. And the other thing you remember is that people start skiing usually when they're children in their teens, and they keep skiing. And if you've skied a black run when you're 20, you're going to keep doing that run until you're 70.
Yeah.
But at some point, biology lets you down and the strength lets you down, and you've no longer got the strength or the control to manage that.
Yeah.
And we see injuries are more common as people are fatigued at the end of a day, towards the end of the holiday, multiple runs.
Yeah.
And I think people just keep going and having not been conditioned for it.
Yes.
And so that's when the injuries really happen.
Yeah. So ACLs, everyone assumes you need to reconstruct an ACL.
Yeah.
Is that the case?
No, not at all. A lot of ACLs end up having a reconstruction or need reconstruction, but not all of them at all. And it really comes down to the patient's. Firstly, it depends if there's a meniscus problem or something else.
So
you might
other
want to operate on.
collateral sort of problems.
Yeah. And let's say there is not, then it really comes down to what they want to do. You are you need the ACL to do rapid, high-speed pivoting.
Yep.
Particularly if there's some sort of degree of competition where there's a bit of adrenaline.
Yeah.
That's where you need it for. To do straight line activities.
Rugby, football, basketball, maybe skiing.
No,
but
skiing, paddle.
Yep.
These kind of things we see now. But if you want to go to the gym, to run, to cycle, to do CrossFit type stuff, you don't need an ACL for that.
Yep.
And so I'm often having to push back on people and go, look, do you really need an ACL? And so a lot of patients come to me saying, I've torn my ACL, I want an ACL reconstruction.
Mm-hmm.
And so people, when they tear their ACL, tend to go into three groups. There's one group who do the rehab, do the recovery, and get back to doing most things they want to do.
Yeah.
It's a small group, but there's a group.
How do you designate them? Because I sort of designate people as copers and non-copers.
Yeah.
And there's some interesting papers that almost simplify this approach, that if someone can walk very well, maybe with a little bit of pain, but very minimal mechanical symptoms, within a week of doing their ACL, they fall into a coper category. And they may do fine depending on what they want to get back to.
And some people fall into that category even at later time, once the swelling has gone down. So there's that one extreme who can manage the knee.
Yep.
And then there's one group whose knee is so unstable it falls over when they step on a curb going downstairs.
Yep.
That's really rare.
Yep.
And most people, in my experience, 90% fall into the middle group, which is they do the prehab, they do the recovery, pain goes, swelling goes, range of motion comes back. They can walk, they can run, they can cycle. You would never know watching them they have an issue, but they then either go back to pivoting activities and experience some instability.
Yep.
They have an ACL reconstruction.
Yep.
And actually, one of my large cohorts are people who go, I want to do these activities.
Yes.
I don't want to think about it.
Yep.
I don't want to have a problem or worry about it. Just reconstruct my ACL.
Yep.
You get. And then I get on and do that.
Yeah. So do ACLs heal? There's quite a lot of conjecture. There's some different bracing protocols out there, the cross bracing protocol. Yeah.
Cross bracing,
protocol out there. And there's a lot of physios out there and other specialists who are claiming sort of radiology and imaging showing sort of, or demonstrative sort of healing within an ACL. As a knee surgeon who goes in and sees it, do you see that ACLs can heal?
So I do think some ACLs can heal,
Yep.
but it's incredibly rare.
Okay.
If you ask me so I see a lot of ACLs. I probably see a dozen ACLs a week.
Yep.
Right. And if you say how many ACLs do I think I've seen in the last 11 years as a consultant, 18 years since I was a registrar that have healed, I'd probably say a handful.
So we're talking a handful on one hand?
One hand.
Yep.
And
is that because you're not seeing them down the line because they're coping and they don't need to come back to see you?
I'm talking, so that's not unreasonable. And I'm not so blind to say that my experience is all encompassing, but I do follow them up for quite some time.
Yep.
Because I'm very much of the opinion, so if I see an ACL, unless they've got an urgent reason to operate like a bucket hand or meniscus,
Yeah.
go and have 3 months of prehab
Yep.
and come back and see me.
Yep.
Work with your physio, talk to your physio and see how you get on.
Yeah.
And if people come back and they go, well, actually, it's been fine. I've had no instability. I go, well, great. Go to the next milestone. And I progress them along the ACL rehab pathway. They just go quicker. And if they can get, and I've had people who can get back to certain activities and certain sports. Some people get back to tennis and things like that.
Yep.
Without ACL reconstruction. But if you talk about healing capacity, so when you look at the studies that talk about, particularly the cross bracing, in that protocol, a fair proportion, if I remember rightly, I think about half the patients who had cross bracing still end up needing surgery.
Correct.
So you have 3 months.
And it's a pretty aggressive protocol.
Yeah.
You've got your knee in 90 degrees of flexion
in a brace.
For 12 to 16 weeks.
For 12, yeah, absolutely that. But 3 months on average. And then there's still a 50% chance you might need an operation.
Yeah.
And the other thing is that a lot of the time, healing is defined as a normal looking ACL on an MRI.
Yeah.
That's now black.
Yeah.
And that doesn't actually tell you anything about function.
Yeah.
And the ACL and the meniscus and ligaments in general around the knee are best assessed dynamically on stress, not on a static MRI when you're lying on your back. See, the thing you understand, let's say you've got your ACL, a diagonal structure that's running across the knee, and let's say you've torn it in two and the fibers are completely displaced and they're nowhere near each other. They can fall back and sit in the right place.
Yep.
And on that lateral x-ray, you look from the side, that diagonal looks like an intact ACL. But the minute someone does an anterior draw or a Lachman test and you pull it apart,
It pulls.
the fibers, it's unstable.
Yeah.
And the second thing that the ACL does is rotational. And you do a pivot shift and the knee is unstable.
Yeah.
And so I'm not here looking for more work or saying all ACL should have surgery and they never heal. I'm saying I think they very few, if any, heal.
Yeah.
Very few. No, not, if any is unfair, very few. But I'm not saying they all need surgery.
Because, look, I probably see nowhere near in the realm of you, but I probably see 50 to 75 ACLs a year.
Yeah.
And there's a decent cohort whereby they're reported as a full tear, but Lachman's, which is a stress test that we do,
dynamic test.
and a pivot test, which is another stress test, they're very stable. And I wonder whether the ACL can bind down to the PCL.
It does, yeah. And that can
some
happen
of the time,
depending on the type of tear that you have.
Yep.
Absolutely. They're particularly a proximal tear.
Yep.
They can stick to the PCL. But in my experience, that will give you front to back AP stability.
Yep.
Because it's not attached to the lateral wall. It won't give you the rotational stability
Yep.
still. And you see people there who've got a rock solid Lachman, no anterior draw. Pivot shift is there, positive, and they feel unstable when they turn quickly.
Yes. Yeah. Okay. So in your view, healing can occur, but it occurs very, very rarely.
Yeah.
ACLs, so conservative management can be indicated or can get people to a good functional level if they don't want to do pivoting rotational sports.
Yeah.
Would you account for the hypermobile individual, so one who has excessive joint laxity within your decision making? And would you ever use a brace in those patients who have had conservative rehab and they wanted to maybe ski?
Yeah. So the hypermobile, the fact they're hypermobile probably means that they're less likely to achieve stability.
Yeah.
But I would still always start everyone off with 2 or 3 months of physiotherapy-led ACL prehabilitation.
Yeah.
Come back and see me, review your symptoms. If you are unstable, it doesn't feel right, we'll talk about surgery at that stage.
Yep.
If it's stable, go to the next milestone. With regards to bracing after skiing, I think it's a very sensible thing. Wearing some of those big kind of the Donjoy Force Point, the Osso CTI brace is not a practical thing to do for playing basketball or paddle.
No.
But where
For skiing.
But for skiing, I would recommend it. And actually, the one thing I've changed my tune on over the last kind of 10 years is that when I first started, I say, you don't need a brace to ski now. You've had your ACL reconstructed. And then 5-6 years ago, I started adding in a lateral tenodesis, a seat belt to protect the ACL graft.
Yep.
And now I'm kind of like, there's no harm from wearing a brace to ski.
Yeah.
And so I tell people that I think it'd be worthwhile.
Does that depend on their genetic profile in terms of whether they're hypermobile, or does it depend on male, female?
No. I pretty much as a rule now, I'll say to people that it doesn't necessarily have to be a big post-op brace, but a hinged knee brace, one of those small little ones with the hinges on the side. I think it's worthwhile getting one of those. And if someone's not had their ACL reconstructed, I recommend the Force Point or the CTI, the big braces, the carbon fiber ones.
Because interesting, I often, when people returning to ski, I tend, even the females who have had a reconstruction, because of the physiological differences between male and females, in that they're generally not able to generate as much strength or as force, and the forces that go through your knee when you're skiing with those big long
huge.
So I tend to even suggest to the females who might have a bit of hypermobility about them that actually a CTI brace might be a good shout to just try and protect them as sort of a belt of braces.
I think it's really sensible. And as I say, I've definitely pushing more towards bracing people who are going to ski, whether they've had their ACL reconstructed or not.
Yep.
Because obviously that would also limit any injury to meniscus or cartilage as well if they've got more control of the knee.
Yeah.
But for normal activities, I would not normally recommend a brace. Normal sports,
Yeah,
because you would expect that the strength and the control
they should
be fine.
Exactly. So rehab post ACL is probably one of the lengthiest rehab pathways.
Yeah.
But actually, oddly, rehab after a conservative, often can be significantly quicker than after an ACL reconstruction, isn't it?
It is, and I have this conversation, and actually it goes back to your very first question as well. Is that why do people fear knees? It's because they think, well, I've torn my ACL, I'm out for a year.
Yeah,
and it's the psychological and the physical impact of that.
Yeah,
not being able to do the things they love and being doing physio.
Because
and exercises daily.
It's a pain. I sort of tell people, look, your surgeon's going to do a little bit of the work, and actually, the biggest, hardest factor is you doing the grunts of rehab and strength work for the next 9 to 12 months.
I have this conversation multiple times a day. The operation is the easy bit. I will give you.
I'm not taking away your skill set.
I know, I'm giving you it because I'm saying that once the operation is the easy bit, that we do so many of them.
Yeah,
that's pretty much fire and forget. The ACL's done, and then it's down to the rehab. And the thing is that I did a video on this on my Instagram. Surgery rebuilds the graft, but rehab rebuilds the confidence.
Yeah,
and it's rehab where stability becomes performance.
Yes, but does also rehab or what's loading the joint has got to stimulate further healing of that graft.
Yeah, and you've got to support the graft through the strength around it. And I think that and when we talk about the ACL functions, everyone knows about the front to back AP stability.
Yeah,
everyone talks about the rotational pivoting stability.
Yep.
The proprioception.
Yeah, because you damage the receptors, and so the receptors need to regrow.
Yeah, so when you tear your ACL, proprioception is the body's innate ability to know where it is in time and space. It's like a GPS of the knee.
Yep.
And so when
you've got a good little analogy.
Thank you. And when you've got proprioception, what happens is within the ACL and the ligament and the capsule, you've got stretch receptors, tension receptors, and other sensors. And what they will do is a millisecond before you move, they will fire off thousands of impulses to your brain to say, I'm about to move, fire my VMO, fire my quad, fire my glute, fire my this. And that controls the knee. And when you tear the ACL, you don't have that. And that's why people lack confidence in their knee when they've torn their ACL. And with an ACL graft, you're taking a piece of tendon, trying to make it a ligament, and it never becomes a full ligament. And so the rehab is a thing that retrains the brain to get proprioception, but it's never the same as the native ACL. That's why there are some people who don't get the holy grail of the forgotten knee.
Yes. How many patients do you think can get to a stage after an ACL reconstruction to go, you know what? I don't feel it.
Not as many as I'd like. So we call that the forgotten knee.
Yeah.
And certainly much less than half.
Okay.
Much less than half.
Every now and then. Because they don't complete the hard process right to the end?
So I'd like to blame the patient and say it's not my fault. But no, I think it is the fact that you've torn what God gave you.
Yeah.
Or whoever you believe in. and you've basically replaced a ligament with a tendon,
Yeah.
which doesn't have it doesn't have the same capacity or capabilities.
Yeah.
And so I think it's just the fact. So yeah, for some of them, they've not done the work and regained the strength, the control, the conditioning. For some of them, they have done that, but it's just that they haven't got the proprioception back to the level they had before. And an untold amount, unlimited amount of Bosu ball single leg squats are never going to achieve it.
Yeah, yeah. So, just touching on graft selection, typically hamstring graft has been the favoured graft choice for people.
For Europe and Aussies,
Yep.
not in North America.
They've used sort of bone patella
Patella tendon
graft.
was overwhelming in America.
Yep.
I would say it was on the order of 90% for decades.
Yep.
And quadriceps tendon has come along.
Yeah.
And America has exploded. It's still nowhere near as much as patella tendon, but it's now by far the second most popular graft in North America.
Okay. And where do you think we'll be in 5-10 years with sort of graft selection? Do you think that we'll be doing a mix of hamstring and quads tendon?
Yeah. So my practice has changed quite a lot. I was doing 90% hamstring 5 years ago.
Yep.
Now I'm down to 60%.
Okay.
I was doing 0% quads 5 years ago. Now I'm doing about 20% quads.
Okay.
And
then
about 15% patella tendon.
Yep.
And 5% allograft.
So how do you make that choice of what graft is appropriate?
So it's a discussion that I have with patients daily, and actually I wish I'd find a way to just save myself the chat because I've complicated my own life.
Well, we're recording this, so you can replay.
Hamstring.
Yeah.
So if someone is an elite athlete,
Yep.
a professional footballer,
You won't do a hamstring.
patella tendon.
Yep.
It's bone in the tunnels, fixed righteously with screws.
Yep.
Quicker healing.
Yep.
Quickest return to sport.
It's a stronger, generally considered a stronger graft.
So every ACL graft that we use is stronger than a native ACL.
Yep.
And actually, a 4-strand hamstring is not particularly is about the same strength as a patella tendon.
Okay.
As a quads tendon. We know the allograft are probably the weakest ones in testing, but they're still stronger than a native ACL. But with a bone block, because it's fixed, it heals quickly. It's a righteous fixture. It fuses into your bone.
So the graft to bone aspect is the speedier.
Yeah.
Is speedier to heal.
Perhaps within 6 weeks, the bone is healing to the other in the tunnel, and is really strong. And that's why some athletes will get back up early as 6 months back to playing, but really near 8 or 9, but as quickly as 6.
Yep.
With the soft tissue grafts, the hamstring graft, the quadriceps graft, when you have a tissue that's fixed with screws or with buttons and suspensory loops, there's some chance of it stretching to some degree. And so the conversations I have, so if someone's an elite athlete, patella tendon graft, if someone's torn their ACL before, as in they've had an ACL reconstruction, it's ruptured, and I've got to give them something, I'll go for a patella tendon graft. It's because that. And then...
Because they've probably had a hamstring if it's this part of the world.
Exactly that. And a little bit more. And to be honest with you, so far, I don't think I've revised a quads yet.
Okay.
Maybe because they've not been around long enough. I don't want to go fast and say they don't fail.
We've seen a few quads tendinopathies occurring after quads sort of tendon grafts. Have you seen many of those?
I've not seen any quads tendinopathy, and it's about 20% of my practice. But what I do see is that quads switch off. And the quads are slow to get going. A lot more role for BFR and muscle stimulation. And I tend to keep them on crutches for a little longer, 4 weeks, sometimes up to 6 weeks. Not
6 weeks.
Not for meniscus purposes, purely to protect the quad. Because if you can't fire your quad, that's your seatbelt pretension that's going to stop you tripping and falling and injuring your ACL graft. So if they can't activate their quads, 6 weeks is rare, but up to 4 weeks is quite common.
Okay.
Yeah. So for me, and the other thing about patella tendon is cosmetically, it's a large scar over the front of the knee.
And it can leave you with a bit of anterior knee pain at times.
It can. And so if someone's going to be kneeling on the floor for jiu-jitsu, martial arts, children, family, work, I'll tend to avoid it. Carpet layers, these kind of, anyone's kneeling, but, children, if, for women, unless they're a footballer, I tend to avoid it because it's, cosmetically, not appealing as well. And then, hamstring is kind of the default for most people. But if someone is doing quite an explosive sport or something like football and they play regularly, but they're not professional, or if someone is hypermobile
Yep.
and they've got stretchy connective tissue full stop, then that's a time where I'll be more likely to go towards patella tendon or even more increasingly a quadriceps tendon.
Okay. Fascinating. Okay. Interesting.
Yeah, and I had a patient today who's got a lot of back pain, a lot of hamstring issues, and he said to me, I'd quite like to, and he works in finance. He goes, I'd quite like to avoid weakening my posterior chain.
Yeah.
And I was
Nice.
like,
So everyone,
oh yeah.
yeah, everyone's sort of now starting to talk about and understand, posterior chain and all of those aspects.
Even orthopods.
Yeah, how key they are. So one or two last quick questions on skiing before we touch. We've got to talk about running. Snowboarding, you see less injuries around the knee compared to skiing.
Yeah, like by an order of magnitude.
Yeah.
I think I see hardly any snowboarding injuries.
Yeah. I mean, they injure the wrist, the shoulder.
Clavicle fractures, shoulder fractures, wrist fractures, all upper limb because you fall backwards, you fall forwards.
Yeah.
But your feet are fixed, and how much your knees can twist is really limited because you're locked in.
Yeah.
And there's no torque from these long lever arms.
The board's much smaller.
Yeah. And so ski injuries after, I don't think I've seen an ACL after snowboarding. I'm not saying they don't exist. I see MCLs.
Yep.
But they're quite minor.
Yeah.
Snowboarding, that's why when I did go, the one time I went snowboarding.
Yeah. So ACL injuries are the bigger injury, often other sort of traumas and fractures, but ACL of the soft tissue injuries around the knee, they're the big one that you probably see most from skiing.
Yes, and occasionally, and often ACL, MCL go together.
Yes.
And there's the triad of ACL, MCL, medial meniscus tear. And occasionally we will see a multi-ligament tear where someone's torn their ACL, PCL, MCL, LCL, postural corner, catastrophic knee injury, a potentially life-changing injury.
Yep.
We see those often, and I do see them after skiing.
Yes.
But ACL,
and those ones are usually big fall, higher speed rather than the slow speed ones.
Yes. Always.
Yeah.
Yeah. Huge force on the knee.
Yeah. Okay. We're not going to dive into that rehab or anything like that, but what are one or two key things that people could do to try to prevent knee injuries with skiing, apart from not skiing?
No. So, no, I think you should ski if you love it. I mean, people seem to love it.
Yeah. It's amazing sport. Yeah.
And I've been to the top of a mountain a few times, and the view is fantastic, and the drinks and food up there are great.
Yeah.
But the number one thing is people don't prepare for ski holidays. I think you've got to train for it, almost like you're training for a 5K or 10K.
Yeah.
Be strong.
Yeah.
And the more strength and conditioning that you have in advance of going, there's that. And as well as strength, you need conditioning, you need endurance, because people get tired at the end of the day.
Yeah,
and a lot of injuries happen on the last run.
So you need resilience.
Yes.
So that comes down to good strength training. You've got to squat because it's not bad for your knees. And, very specific to the skiing position, build posterior chain strength, glute, hamstring,
core,
stability, core, the whole thing. Plus some cardiovascular because you need that endurance capacity.
Yes, and I think people really should train to go fitness-wise in the gym in preparation for going skiing.
Yeah.
Particularly as you're getting older.
Couldn't agree more. That's why we put out lots of ski fit sort of videos, and we try to prep and encourage people to do that because, people are desk jockeys.
Yeah.
And they go, I'm going to go for my week skiing. Yet they don't do any leg strength and wonder why they come back with an injury.
For sure.
Okay. So running. Do you run?
No. I'm going to this year, actually. So I started strength training about a year ago. I've run previously and then work and life and family got in the way. And I started strength training from scratch a year ago. And I do that 2-3 times a week.
So how much better do you feel in yourself from strength training?
Unbelievably.
And I haven't prepped you with this question at all, have I?
No, and I've lost 23, 24 kilos over that time.
That is unbelievable.
Yeah. And so that coupled with strength training has transformed my ability as a surgeon to stand and operate, as my endurance, as playing with the kids, just feeling tired, feeling niggles, aches and pains. No, I feel better in every single way.
Amazing. And so, I mean, strength training is the biggest thing that we try to push people to do to optimize their health across the board.
And listen, I squat with weight, I deadlift, I do front squats, I do classic squats, I'll do,
back squats.
Back squats for sure.
Yep. Amazing. So and we'll dive into that in a second. So is running bad for your knees? Does it damage the cartilage?
So the evidence, if you look at the literature and systematic reviews and meta-analyses, have shown repeatedly that running if you don't have damage to your knee,
Yep.
firstly, does not cause damage to your knee.
Yep.
And actually, regular runners have a lower rate of osteoarthritis than people who are sedentary because cartilage responds well to load.
There you go. So regular running can improve your ability to reduce the risk of osteoarthritis.
Yeah, it can actually, it's beneficial for cartilage.
Yep.
And I'm talking about running within sensible, appropriate parameters.
Yeah, okay.
I'm not
So
talking about people doing 100K
Yeah.
every
So
Saturday.
5K 3 times a week.
For sure.
Yeah.
10K twice a week and a 5K.
Is there a type of knee injury that perhaps can be accelerated with running?
So if you have a hole in the cartilage, the lining at the end of the bone,
Yep.
and it's in the weight-bearing zone, and you keep pounding it, then the chances are that, like a pothole in the ground, it will never repair. It will progress with time.
Okay.
But interestingly, the evidence is still that people who have osteoarthritis who run do not. So I'm talking about a specific focal cartilage defect.
Yes,
If you've got
yes.
arthritis, generalized thinning of your cartilage, the evidence is still clear that running does not accelerate X-ray changes,
Yep.
does not accelerate pain symptoms,
Yep.
and in certain people can reduce their pain with osteoarthritis.
Amazing. So you're an advocate if someone wants to run, and so long as they've got sufficient strength, because that for me is the caveat here. Someone needs to be strong to support the joint.
And the one problem I have with the runners is the fact that a lot of them are nutters,
Yeah.
is the fact that many of them don't do strength
Yeah.
work.
So that's
They'll
the
just
biggest defect or the biggest issue that we see in runners who come in as patients, in that, okay, they run 50K a week, but they do zero strength training. And there's lots of asymmetries in terms of their strength markers
For
from
sure.
side to
And
side.
that's the challenge I have with them. But running in itself, and obviously the psychological benefits, the cardiovascular benefits of
Yeah.
it. I think I think it comes down to, as long as your knee's stable and you haven't got a big focal cartilage defect that's
Yep.
painful when you pound it.
Yep.
And if you've got arthritis, you can still run.
Yep.
I think it's a concept of load tolerance.
Yes. And how I think we try and spend a lot of time sort of educating patients to go, well, look, okay, if you want to run a marathon, you've got to build your load. And that's perhaps not sensible for where you're at the moment because you don't have the strength to support that. But if you want to run, 2 or 3 times a week at sensible limits, 5 to 10K possibly, okay, we can build the support to allow you to do that.
Yeah.
And that should not cause any further trauma to your knee.
So I say to people that I kind of say, look, the normal load tolerance for knees up here. And I put my hand up here for people who are listening.
Yep.
And then with an injury and muscle atrophy, your load can come down. Your load is here.
Yep.
And with a bit of strength and conditioning, it can come up. And say you're missing cartilage.
Hopefully a
or
bit more than
meniscus.
what you're showing,
Yeah.
but yeah.
But for meniscus cartilage, it may not go back to normal. And then the question is, where do you sit relative to that load line?
Yep.
And if you're underneath that line, it might be 5K twice a week, a 5K and a 10K is fine. 2 10Ks, too much, pain and swelling, dial it back, focus rehab a bit further,
Yep.
and try again and see where you're at. But pain and swelling are the things that tell people that you are doing too much load on that knee and the knee does not like it.
Yep.
And so dial it back. And also I would always encourage people never to run on a swollen knee.
Yes. Okay. So big takeaways are that you don't stop people running.
No.
Running can actually help accelerate and improve cartilage.
And particularly in people who've got normal knees.
Yep. There's some people who are carrying a lot of weight where running increases force that may not be great.
By huge multiples.
Yep. And modulating running technique can be useful. And probably the biggest thing that I tell people is managing their cadence.
Yeah.
So a faster cadence seems to reduce the load.
Stride length, the position
Yep.
of their foot strike, the footwear that they have. As you know this far better than I do, so forgive me if I'm teaching you how to suck eggs. But there's so many modifiable factors that go just beyond don't run.
Yeah, completely. So awesome. Kash, we have almost covered our questions, but we're sort of out of time today. And that's been super interesting. I think I've had a great chat with you. It's been really, really interesting. And I hope all our listeners will be excited to sort of hear some of this. So thank you so much for your time and your wisdom, and we'll have to do this again soon.
For sure. Part 2. Thanks, buddy.
Thanks very much.
Appreciate it.